thank you so much for being here today. So I'm LJ, I'm a respiratory consultant at King's, and I'll just be talking you through some of the work we've been doing on looking at sustainability in terms of respiratory care with a particular focus on inhalers. So just to remind you of the situation in the NHS, I'm sure you will have seen these diagrams before. So when the NHS pledged to go net zero, there was a big scoping exercise looking at where most of the emissions came from, and that gives us this diagram here with scope 1, scope 2 and scope 3 emissions. In terms of some of the hotspots, you can see metered dose inhalers are highlighted here as a specific contributor to the carbon footprint of the NHS. So there are two sort of clinical aspects alongside all of the other things like energy, traffic, travel and fleet. The kind of two things in terms of medications are anaesthetic gases and MDI inhalers. So they were real focus for us at King's in terms of our green plan to think what can we do about these two areas. And so we established two project groups in order to focus on these things, including members of the clinical teams as well as quality improvement and other people within the trust that could support these projects. And when we think about inhalers, there's quite a lot of work already been done on sustainable inhaler prescribing, and there are some really fantastic toolkits available, but they are focused on primary care. So there's quite different needs and options for reducing the carbon footprint of inhalers in primary care. And so it's a bit more tricky in secondary care. And so we didn't have a lot available in terms of established quality improvement processes or even really access to data. So if you're in primary care, I'd really strongly recommend having a look at the Greener Practice website, or if you have any colleagues, because there's ready-made projects ready to go and they integrate with things like the EMIS system. But in secondary care, we had some slightly different challenges. So we set out to look at what the carbon footprint of our inhaler work was, inhaler prescribing was, and the main question we had was what was the split between metered dose inhalers and dry powder inhalers, because there's a vast difference in terms of the carbon footprint and the environmental impact of these inhalers. MDI inhalers include hydrofluorocarbons, and they are very much greenhouse gases. Dry powder inhalers don't have this problem, so they don't use propellants and therefore don't have such a high carbon footprint. So we looked at what was the prescribing practice within the trust, and you can see here some graphs looking at the period of 1920 and 21-22, and the predominant inhaler type is MDIs. So an MDI inhaler has the equivalent greenhouse gas emissions of a car driving from London to Sheffield, whereas in comparison, the same greenhouse gas emissions for a car for a dry powder inhaler is just 4 miles, so driving across London. So there's a very big difference there. So we looked at what from the numbers of inhalers that we dispense, we looked at the carbon footprint from inhalers at King's, and it was 272 CO2, and we therefore focused on looking at what we could do to change this split between the MDIs and DPIs. And we followed a methodology from the Flow Coaching Academy. King's at the time was in the first year of becoming a Flow Coaching Academy, and the Sustainable Respiratory Project was one of 3 that we selected for use on this FCA roadmap. And lots of the components of the FCA programme will be familiar to anybody involved in quality improvement work, but there are some slightly different terminology. So there's a real focus on the 5 V's framework, looking at understanding the current state, establishing a global aim for the project so that there's a shared vision, and then setting up a big room, which is the regular meeting point. And the big room has some structure around it to make sure that everybody gets a voice. And then moving on from there, you can identify root causes and then establish some change ideas and go through the familiar PDSA cycle. And the other value to the FCA programme is there's a focus on coaching. So thinking about what skills teams need as well to make change happen, as well as the practicalities. So we established our big room and we established our global aim statement built around the idea of sustainable healthcare, and we kind of identified some barriers that we'd seen and experienced, and some of these may well be familiar to people. Pace of change was one that was always tricky. Time, feeling disempowered, siloed working. They'll be very familiar, I'm sure. What we established was that within a secondary care, a large organisation, there are lots of different teams involved in inhaler prescribing and dispensing, and so it happens in a kind of distributed manner. It's not focused in one area. And so a real key point was to involve the pharmacy teams from very early on, as well as prescribers, and that really brought real benefits, thinking particularly about processes. And then we started to define what our outcomes and processes were that we'd want to track over time, and identified additional people within the project team. And then we came up with these aims and measures for the project. So the key thing was to reduce the inhaler carbon footprint. And to do that, we looked at a number of different factors. So decreasing the use of MDIs as a proportion of the numbers of inhalers that we dispense, looking at improving the access to alternatives. So we identified the fact that for patients who were given inhalers on the wards, the only option for a salbutamol inhaler was a MDI inhaler. There were no dry powder inhalers available, so clearly the only things that were given out by the nurses or by A&E were going to be the things that are available, rather than waiting to get things from pharmacy. So there's a real barrier there to different practice. We identified the difficulties around disposal of inhalers. There's no national recycling project or disposal, but that was a very difficult one. We didn't have a baseline. There was a lack of data around whether inhalers were being returned. So one of the challenges here was that some data is just not collected. And we identified a real hotspot of use, which was within our chest unit. So patients come to our chest unit for investigation. They have breathing tests done, and as part of some of these tests, an inhaler is used to check whether their numbers change after the dispensing of that medication. And this was a huge area within the trust of use of MDI inhalers. So we identified that as a real target for improvement work. And what I would say is that the key thing here is to get access to the right data about where in the trust the inhalers are actually being used and dispensed, so that energy can be targeted in those areas. And one of the challenges we had, so of the 68,000 inhalers recorded as prescribed, the amount recorded as ward issue was 39%. And a real challenge here is that actually what the process is that inhalers are kind of stocked on the ward, and then there's not close tracking as to when they're actually issued or used. So they can kind of sit on the ward and be part of the numbers. But of the 26,500 inhalers issued to wards across all sites, 99% were MDIs. So we can be pretty confident that all of those ones definitely significantly add to our carbon footprint. And as we've said, when we looked at what ward issue meant, the chest unit comes up as our biggest ward area. So again, this is about understanding the data, and we may have assumed that all of that was happening on inpatient wards, but actually when you dig down into what those terms mean, the chest unit accounts for 20% of the trust's combined MDI prescribed inhalers. So it's about really understanding the data and its limitations, and then being able to work on the areas that can have action. So this is a little bit small perhaps, but this was a root cause analysis that was done by the project team, and it was really useful to have the whole team, everyone involved in this process in the room to create this root cause analysis, because we had input from respiratory nurses, from pharmacists, from A&E physicians, and respiratory specialists, and kind of identified different barriers for different areas. But there were some key problems agreed: lack of time to educate patients about the different options for inhalers, lack of access to alternatives, and the process for prescribing was identified as a barrier because on our electronic prescribing system, there is no information about carbon footprint of the different inhalers. So someone would type in, for example, salbutamol, and it wouldn't be clear from the options available to them which were the high carbon inhalers and which were the low carbon inhalers. And even in many cases, it was not obvious which were the metered dose inhalers and which were the dry powder inhalers. So even being able to tell the sort of device is often challenging because things are prescribed very much by their brand name, and not everybody has great awareness because the inhaler landscape has changed over time and is much more complicated now. So we identified quite a number of key things that we felt we could improve on. And then we had a rapid improvement event with all of the team members and drew out what kind of some ideas for changes that we could make in driving this change forward. And we drew these together into a driver diagram, mapping these changes, how they would drive the change. And so then what we did was to rate these by possible quick wins and then longer term strategic initiatives. So within quick wins, we identified a number of things, well, what we thought might be quick wins. Quick wins don't always turn out to be as quick as we would like, but certainly developing um, uh, a dashboard was key to understanding how things changed, thinking about awareness weeks, staff education, and developing a low carbon inhaler comparison guide so that information was more easily available to staff. And then things about simple things to try and encourage patients to return their inhalers to pharmacy. So developing stickers to stick on to inhalers when they were dispensed from pharmacy, just to give them that little nudge instead of putting them in the bin at home, to bring them back to pharmacy. And we started to look at reuse of the inhalers used within the chest unit. So the current practice is that each inhaler was only used for a single patient, so most of the doses were wasted. So we looked at how we could change that and how we could get around the barriers that were due to infection control. So that was a key area of focus. This was one of the challenges, so things that we thought would be quick win in that they didn't need new equipment or investment, they just needed a change in process, included the need for external teams, so infection control in this case. So that did slow down that process. And I think, yeah, being realistic about capacity is important at this stage to say where have we got leverage and where have we got energy to be able to make a change. And then we looked at longer term things that we thought would make a difference that would definitely then continue the change. And one of the key ones for that was changing how the inhalers appeared on the prescribing system, so on our electronic prescribing. And so that obviously required work with the team who are able to make changes to that system, so with the IT team, and some work with prescribers as to what would be most useful in terms of how the inhalers would appear and the information available. So that was identified as a key strategic aim because it would have longer lasting impact rather than just an education campaign that obviously only captures so many people. And so that was a prioritized long-term strategic aim. So these are just some of the things that we've done so far. So you can see here an example of a mock-up of the new EPMA prescribing system appearances. So trying to identify, okay, so if you're a prescriber, you want to prescribe a short-acting bronchodilator, and so having the information available about which of those is low carbon and which is high carbon in an easily identifiable format is very helpful. We've developed some different resources. This one is a poster for patients, which is aimed at helping them to improve their inhaler technique, which is another key part of sustainable respiratory care. But you can see that there's a Green Champions logo. So we're highlighting those inhalers which are more sustainable. So they're dry powder inhalers with a lower carbon footprint and with some messaging around that too. And I think one of the key things here is to link the messaging of good clinical care with low carbon care. They're not in opposition, they are in parallel and go alongside each other. And then some information for prescribers, again, about which of the inhalers have which inhaler footprint, and again, that reminder of the difference in terms of the vast difference because of those greenhouse gases. And this is the sticker that's going on to dispensed inhalers, along with an information leaflet about returning to pharmacy. And this is our dashboard. So it's really important to have a good grasp of what's happening over time and an understanding, and it's really motivating for the team to be able to see what's happening and what the numbers are and where we can work on things. So this will help us to continue to monitor to the current impact. One complicated factor is that the carbon footprint in our green plan, which we have used as our baseline, was a sort of estimate, not based on actual numbers from dispensed inhalers, more based on financial data. And so we're working on re-establishing that baseline using historical data. So that's going to mean that we can then more accurately see our impact. We've also obviously had the pandemic, which has had a big impact because we had many fewer patients coming to the hospital with things other than COVID. And so we have some change in both overall use of inhalers, but also our chest unit usage. And you can see with the pandemic, we weren't doing spirometry because of the concerns about aerosolization. So there was a huge drop right down to here, but this has gradually come back up again. So it's a real focus. So at this point, we're kind of back to a normality. And so then what we'll see hopefully is a further dip down once we've been able to establish a process with our infection control team, which is currently under review. Very excitingly, we have agreed a process that we think is acceptable. So what I would say is that this is quite a complicated pathway within a secondary care environment, because there are different places where the inhalers are dispensed and used, which have quite different needs in terms of the departments and how they might be able to change. But a systems approach with all of the right members of the team working together and identifying the challenges is really the way to go. And understanding the process through QI methodology has really been of huge value to determining where the best places for actions are. And as I've said, a multi-professional team has been essential to solving some of the barriers. The prescribing behavior change is slow, but it does work with consistent messaging, and we are seeing that. And as I've said, it's vital to align the narratives of best clinical care with the most sustainable care. And that's really the way that we can get staff on board and also patients on board too. And the biggest wins are often from places that you would not necessarily realize. And so understanding that data at the beginning, where the biggest hotspots are, is really important for then determining where to put the energy in. And that is it. So thank you very much for your attention.
Fantastic. Thank you so much, LJ. That was a fantastic presentation, and I can already see some questions coming into the chat. So if you have a question for LJ, please pop up your hand or put a question in the chat. And I can see one from Maxim straight away in terms of was it possible to get the templates? Were they the templates for the posters, Maxim, or? Yes.
Yeah, they look very neat. So if I could have these, if possible, to share, that would be brilliant, rather than to reinvent the wheel.
Yes, I would say definitely don't reinvent the wheel. So we are also reusing other resources. So for example, some of the leaflets that we've got are from the Greener Practice website. So they are also excellent. So I would have a look on there, and yes, very happy to share.
Brilliant, thank you.
And a question from Savjani in the chat. Do you know which figures you're going to be using to calculate carbon footprint of inhalers when calculating according to numbers dispensed rather than financial expenditure?
Yes. So maybe there's two bits to that question. So one is the actual carbon footprint per inhaler. We're using PressSquip data, which is the most up-to-date version, and that's available online. I can't remember what PressSquip is. It's like a pharmacy site, but that's felt to be the most accurate, up-to-date version of inhaler carbon footprint. So that's what we're using. And then in terms of the numbers, rather than financial data, we're using actual dispensing data. So that's all from our pharmacy. So the actual numbers of inhalers of different types that are dispensed. I hope that answers that question.
Thank you. And then the next question was Alexandra putting her hand up, I think. So please, Alexandra, go ahead.
Yeah, hi, Alex Powell. I'm a consultant paediatrician in Somerset. I'm obviously I'm hearing some really good things, and I'm really passionate about sustainability. But in paediatrics, as a respiratory physician, we're obviously faced with children not being able to use DPIs in the same way, and so MDIs are being used. Did you involve your paediatric team in your trust, or is there any thoughts about how to reduce the use within the paediatric department?
Very good question. So we did engage with our paediatric colleagues, and we did have quite an enthusiastic registrar for a while attending our big rooms, but there was some resistance in some of the prescribers. I think there's a lack of confidence, and I think that will change over time. So there is an age kind of rule around the use of dry powder inhalers, but actually in Wales they're dropping that, and I think there will increasingly be work more nationally which will show and support the use of dry powder inhalers in younger people where that's possible. And I think it probably be at that point that then more local teams will feel more confidence. I think at the moment, with the guidelines being quite black and white, people don't feel that confidence. So I think the key thing probably in paediatrics is to think about transitioning people when they are of the appropriate age, and also other aspects of good clinical care that reduce carbon footprint. So, you know, really good asthma control is the most low carbon care you can give, because if we're preventing exacerbations, we're preventing admissions, and if people are using their inhaled corticosteroids well, they'll need many fewer of their reliever inhalers. So there are other things to do, but the switching to dry powder inhalers is a bigger challenge.
Brilliant, thank you. And there's another question in the chat from Charlotte. So many inhalers are prescribed in primary care, and there's lots of similar work going on in PC. Do you connect with them all at all, or follow a similar process? The clinicians I'm working with are hesitant to run our own project before the PC process is embedded. I don't know what PC means, but I
think it just means primary care, maybe.
Right.
Yeah. So yeah, we've got some really great work locally in primary care. Our greener practice groups are very active, and we have worked with them. I think the needs are slightly different in that obviously there's big overlap in terms of changing prescriber behaviour and improving knowledge, and in supporting patients in terms of thinking about using the NICE decision aid. So that's all very much shared between primary care and secondary care. And it is really important that patients hear the same messaging. So I think getting that right is important. We've also worked at sort of ICB level a bit, as in there's a pharmacist who's very keen on this, and so we're aligning the interventions that we're doing across our different trusts and across primary and secondary care, and just picking the things that we think are most relevant to our situation. So that's partly why we focus so much on the chest unit and on looking at alternative available inhalers for our wards, and focused a little bit less, although still have done, in terms of individual patient interventions, which are happening on an ongoing basis in clinic, but are probably not where we're going to make the most difference within our footprint within the hospital, whereas in primary care there are different opportunities. So I think that the messaging and working together is really important, but we probably have different areas of focus where we could make the most difference.